Welcome to our cutting-edge online point-of-care ultrasound fellowship program. We are excited to invite you to this pioneering fellowship designed to empower healthcare professionals with advanced skills in acute care ultrasound. As a participant, you join a diverse global community committed to transforming patient care through innovative ultrasound practices in critical and emergency settings. Our comprehensive fellowship is meticulously structured into 2 immersive modules, each spanning 24 weeks. Whether you're just beginning your ultrasound journey or you're a senior clinician refining your expertise, this program is tailored for you. Our curriculum bridges the gap between theory and practice, providing an evidence-based, clinically relevant approach to ultrasound education. You'll explore critical applications, including shock volume assessment, cardiac function, and sonal anatomy, lung normality and abnormality pathology, several acute care procedural guidance, several real-life practical case scenarios, and much more. We understand the demands of your profession, which is why our fellowship offers unmatched flexibility. All interactive sessions are recorded and available on a user-friendly learning platform, allowing you to revisit key insights anytime, anywhere. Through expert-led lectures, real-world case discussions, and journal clubs, you'll gain a profound understanding of ultrasound applications, backed by the latest evidence. Our esteemed faculty consists of renowned experts dedicated to guiding and mentoring you throughout your journey. With their support, you'll enhance your skills and stay at the forefront of ultrasound innovation. By the end of this fellowship, you won't just master ultrasound techniques, you'll become part of a global network of like-minded professionals, fostering collaborations, knowledge exchange, and continuous learning in acute care ultrasound.
Thank you very much for being with us tonight. It's my pleasure, Ashraf Al-Tayyar, the Program Director of the Point of Care Ultrasonography online fellowships, including the basic module or common pathway module, and both the emergency and critical care modules. It's my great pleasure to co-moderate this session with my friend and colleague, Dr. Haitham Khalifa, and to have 3 of eminent speakers tonight to speak to us about, as part of our activity in the ED section, they will present their own interesting cases for all of us to learn. This is, as everyone knows, part of the curriculum of the Point of Care Ultrasound ED Advanced section. So as we used to do, we used to meet every 4 weeks. So when we finish the week number 4, we go live on week number 5. This is the second live webinar in the series. And as you know, the program is 24 weeks. So we are about to finish week number 10 today, and next Wednesday, week number 11 will start. Without any further delay, my pleasure to introduce the first speaker of tonight, Dr. Ahmed Al-Sinusi. And Dr. Ahmed Al-Sinusi is Associate Consultant of Emergency Medicine, and he has a board, Egyptian Board of Emergency Medicine, working currently in IMC in Jeddah. Dr. Ahmed Al-Sinusi will present 2 interesting cases. Before I give the mic to you, Dr. Ahmed, let me again highlight some important logistics and housekeeping issues. One of them is when you want the fellows, the attendees tonight, wants to ask any question, please write the questions in Q&A section. And Dr. Haitham kindly will collect these questions and present them to the speakers. And as we said several times before, the live webinar is the great chance for the fellows to present their own cases and to bring their own questions or clarification needed in the previous weeks of assignments on the platform. So please, if not tonight, mark your agenda for the next time to communicate with me and Dr. Haytham to present your cases. I'm talking to the fellows, and this is part of the assignments of your module. And again, my pleasure to ask Dr. Ahmed Sinosi to start sharing his slides and start talking, please.
Okay. Can you see the presentation now?
Not yet, Ahmed.
Okay.
Just try to maybe
Yeah.
you close it and open it again, and then yeah, it's coming.
It's coming.
Yeah, make it full screen.
Yeah. Doing my best.
Good, Doctor. Thank you.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. Today, we will go through a real case, POCUS-based presentation. Actually, it's a challenge. I will not tell you the diagnosis in the front, but we will use our structured approach to investigate an undifferentiated patient with abdominal pain. He's actually in shock. Let's see our patient. This patient is a 74-year-old man. He presented to you in the emergency with sudden acute onset abdominal pain associated with dizziness near syncope. He was sitting at his home and suddenly he has this pain which is radiating to the back, and he started to feel progressively weak, unable to stand. His background include hypertension, dyslipidemia. He is heavy smoker since long time. And when you started to discuss with him the history, he denied any recent trauma, no hematemesis, no melena, no fever. What diagnosis immediately pop up in your mind? I need you to write in the chat before we continue. To give you a hint about his vital sign, he is tachycardic, 128 per minute. His blood pressure is 78/46. This patient is tachycardic and hypotensive. His shock index is a bit high. His oxygen saturation on room air is 96. His tachypneic 28 per minute, and his temperature is 36.4. When you encounter the patient, when you come near to the patient, you find him pale, diaphoretic, and he is restless. He has cool extremity, he has poor capillary fill time. When you started to assess his tummy, he has a bit mildly distended abdomen with diffuse abdominal tenderness. We, as we mentioned in the diploma, when we talk about the abdominal pain, we said that once you found a patient like this, ask yourself, is it a resuscitation problem or it's a targeted or pattern specific problem? Okay, what do you think here? Is it a resuscitation problem we are facing now or an organ specific leading pattern? Actually, it's a resuscitation problem. So what's your differential diagnosis? People might think about GIT bleed, might think about sepsis, might think about PE or abdominal catastrophe like aortic problem. So what we will do now is to start manage the patient using our ABCD approach, resuscitating the patient, and definitely we have to use our bedside ultrasound. Hi, what do you think? POCUS here, it is something like investigating tool. I'll reply saying that POCUS is a resuscitative tool here, not only a diagnostic luxury. What approach actually we will use? When we will find patient in shock, we have to use what's called by rush protocol, giving the all information we mentioned about the patient, about his abdominal pain, and about his vital sign and physical examination. We have to go for a rapid ultrasound in shock and hypotension. This protocol will solve the problem within few minutes. What are the components for this rush protocol? We call it HIMAP. H stands for heart. We will do basic echo for the patient. Then we will go through an assessment for the IVC. Then we will do fast scan. We will assess the Morrison pouch and the whole quadrant in the tummy to look for any hemoperitoneum. Then we will scan the aorta and the lung for pneumothorax. I'll show you the first POCUS finding. We did it for the patient. Please write in the comment section down what view you are seeing now in the basic echo, okay? And what are the findings? I'll give you a few seconds just to write it down. This is parasternal long axis view showing good ejection fraction and hyperdynamic circulation. Okay, normal chamber, no problem in the beginning of the aorta. Rule of 3 is normal, as we mentioned in our diploma and our POCUS practice. Those are the rest of the views. Okay, on the right side of the screen, you will find the parasternal short axis view, same demonstrating hyperdynamic circulation. And on the left side of the screen, there is apical four-chamber view demonstrating the same finding. This is the EBSS, endpoint septal separation, and it's normal. It's measuring 5 milli just only. The finding we just saw, it's a hyperdynamic left ventricular activity, no pericardial effusion, small chambers and normal chambers with normal EBSS. From this slide, we can differentiate two big categories. We don't have cardiogenic shock. We don't have obstructive shock. We might have distributive shock, either septic or whatever, and hypovolemic shock. Let's go for the IVC to continue our journey to diagnose what we have. Okay, as we mentioned, hypovolemic or hemorrhagic. In this view, if you will use your curvilinear probe and you stand longitudinally in the sagittal plane in the epigastrium, you will assess the IVC. You have to get your view till the right side of the heart. By eyeballing without measurement, you can see the IVC is collapsed and it's empty. Okay, this completing the picture that this patient in hypovolemic shock. Our finding, very small IVC, near complete inspiratory collapse. This is second step. We said HIMAP, H for heart and I for the IVC. What does this tell us? That the patient is empty. There is low preload. Then we will go and put our probe in the coronal section, in the coronal plane, in the mid-axillary line on the right side to check the right upper quadrant on the right side of the screen. You will find the anechoic structure, okay, which is a free fluid at the Morrison pouch. And when you will go to the pelvis, you will find free fluid here, anechoic structure, denoting there is hemoperineum and intra-abdominal bleed. Now, this complete our picture. We have hemoperineum, positive fast in a shocked patient, but he is non-traumatic patient. Right. Till now, we have shocked patient, hyperdynamic heart, empty IVC, we have free fluid intraperitoneally, but where is the source? We have to complete our approach to know the source. What diagnosis are you worrying about right now? Actually, you just mentioned it's an intra-abdominal bleed. Once we start the aortic scan, transverse assessment from the epigastrium down to the bifurcation near the umbilicus, we will check the proximal, the midline, the distal aorta in the abdominal side. We found here by eyeballing that there is a big aortic aneurysm. This is by eyeballing. You have to measure it. Don't be deceived with the intramural thrombus. This is false lumen. We agreed to measure it from out to out. Our finding here, we have infrarenal AAA. We have infrarenal abdominal aortic aneurysm, diameter about 8 centimeters with mural thrombus. This will remind me, what is the normal aortic diameter? Please, a few seconds, I'll let you write it in the chat section. And when you will consider the aorta is abnormal. The normal is less than 3. We will consider it more than 3. And if it's more than 5 with hypotension, this means rupture until proof otherwise. So using our rush protocol, give us an idea about what is the patient diagnosis. We have hyperdynamic circulation, empty IVC with hemoperineum, and the cause is rupture AAA. What should happen now? We said that when you use POCUS, it's not the end of the story. What you will do now? You have to shout and scream for the vascular surgeon to activate it immediately, to call him for stat OR to send the patient to the OR, and to call for massive transfusion protocol. But don't forget, in order not to push your patient through the lethal triad, you have to allow what's called by permissive hypotension, okay? And avoid aggressive crystalloid. So always use your high map, which is HIMAP, to achieve adequate mean arterial blood pressure. Use your high map to achieve adequate map, okay? Some pitfalls sometimes happen while we are treating such patients. We are focused only on the fast. We are not using the whole approach. So definitely we will miss the aortic scan. And we might consider that there is history of trauma, and this patient didn't notice, and we will call the surgeon. We will not call for the vascular surgeon. We might assume that this patient has septic shock or other differential diagnosis. If we didn't ask about the symptoms of GIT bleeding, okay, we might consider this patient have GIT bleeding. Sometimes we are resuscitating the patient waiting for the lab. Okay, and sometimes we will do the most unacceptable behavior, which is sending unstable patient to the CT. You will receive his images, but your patient will be coded there. To finalize our case, our take-home message, in a shock patient with a positive fast, the positive fast will tell you here that there is bleeding, but the aortic scan will tell you why this patient have bleeding. And always use your rush protocol. It's non-invasive. You can perform it bed fast. will give you the solution and the rapid solution for a shocked patient with any presentation. Thank you so much. Now, we will go through another presentation with different approach. Actually, we name it POCUS.
Dr. Ahmed, you want to give 2 or 3 minutes for questions?
Question? That's okay. I thought it will be in the end. Sorry.
For this case, what do you think, Dr. Haytham? Is it better if we have the question for this case, because the case is probably different than the one coming?
Yes. Okay. If anyone has any question over this case for Dr. Ahmed.
Yeah. The case highlighted the importance of having a lock in the abdomen for everyone who is presenting with shock, because some of the colleagues, even it's a common misconception that FAST is only for trauma patient. FAST, yes, it means that FAST assessment using sonography to assess trauma patients, but also looking at the abdomen and see if there is a free fluid in the abdomen is considered very, very important. Especially what we used to do in shock patient is to look at the center of the circulation, which is the heart, and then you look at the pipe, whatever protocol you use, to see how is the heart, left ventricle, right ventricle. This will cut, and look around the heart. This will cut the differential diagnosis of shock type maybe 75%. And then when you look at the pipe, you prove what you see on the RV and what you see on the left ventricle, and also pericardial. But the point I want to reach is that looking at the abdomen is not at all inferior to looking at the heart, because the explanation might be there. So this very nice presentation of this case, which Dr. Sinosi presented, highlights the importance of that actually. Dr. Sinosi, the way you do the abdominal exam for aortic aneurysm, what are the hints or tips for exam that you use to make the yielding of abdominal exam using the ultrasound, looking for aortic aneurysm or ruptured AAA, more practical?
Actually, when you have such patient and you will think about the aortic catastrophe, you have to scan the patient from the epigastrium till the umbilicus, till the bifurcation. Sometimes you have a challenge that the patient might have some gases, you cannot see clearly, you have to adjust your image, you have to do some sort of fanning, okay, and sliding from the transverse approach, going down clearly, okay, don't try to exert some pressure, okay, and scan the whole aorta transversely, and each time you will find the aorta, try to measure it, okay, measure it proximally, measure it in the mid way, measure it at the end, okay, and have like an equation, okay, count, multiply the three, okay, sorry, add it, take the sum of the three, then multiply it over three, just to have an average. But believe it or not, once you find a patient like this with only the eyeballing, you will find it distended and it find it ballooning. I don't know if I answered your question or no.
Yeah, it's very clear. Thank you, Dr. Ahmed.
Okay.
I can see here, Habiba, that Dr. Ahmed Abdul Wahab raised his hand to ask a question or to comment. So can you allow him to speak?
Okay, it's much better.
Habiba?
There is one candidate. He asks about that in pediatric patient in shock, if there is any thing specific. Actually, at the end of this lecture, Dr. Hisham will give hints about the pediatrics. And as I think also aortic dissection, aortic aneurysm is less common in pediatrics, but there is a lot of other diseases like sepsis and septic shock, sometimes cardiogenic shock. So the concepts of POCUS is similar in adult and pediatrics, but the diseases are different.
Okay.
Yes.
Dr. Ahmed Abdul Wahab is asking for permission, Habiba. Can you permit him?
He's allowed to talk.
But he's muted. Is it? Can you write, Dr. Ahmed, your comment, and then we'll come back to you as soon as we can. But now we can ask Dr. Asinusi again to go to his second case, please.
Oh, okay.
Yes.
Now we have a POCUS mystery in a patient with abdominal pain. Actually,
Dr.
I
Ahmed,
shared.
we can't see the presentation.
Okay.
We
This is
see
the
the
old one.
yes, the old one. We see the last slide of the old one.
Oh,
There is also Dr. Ahmed Salama, who is confirming on measuring the aortic aneurysm from outer to outer, not to be misleaded by the inner thrombus or dissection inside the aorta.
Yes.
clear now?
Yes.
Yes.
Okay. Now our goal here is simple. Okay, we will demonstrate how to use the bed ultrasound to identify a problem in the tummy. I don't want to burn it. I will go through it. We are seeing a 42-year-old female patient who presents with 5 days of progressive abdominal pain in the right upper quadrant, and the pain radiating to the right of the scapula, and it's associated with nausea, poor appetite, and dark urine. And her family noticed that she has jaundice, okay? And the pain is constant, moderately severe, and when you see the patient, you can see the jaundice clear. I'll ask you here, what additional information you would like to know before you proceed? Definitely in such patient, I need to know the temperature, yes, and the rest of the vital sign. Here are the vital signs. The temperature is normal, 37, okay, heart rate 92, her blood pressure is okay, 120/80, respiratory rate is 18, and she has good oxygen saturation in room air. All right, what else I'd like to know? I'd like to know her physical assessment. She's alert but in pain. You can see the jaundice clearly, but when you go for her tummy thinking that you might find some good sign, you only find a soft abdomen, tender at the right upper quadrant, but no rigidity, negative Murphy sign. I know one of you will say, I'm going there to look for positive Murphy sign. You have a negative Murphy sign, no palpable mass, and this patient is not known liver patient, so there is no stigmata of the chronic liver disease, no peripheral edema, and the cardiac examination and chest examination are remarkable. You continue your history with the patient, but you didn't find just only right upper quadrant pain and jaundice in examination. You will get an IV access and you will ask for lab. Definitely, we need to check the liver function test and CBC, CRP, lipase. And here you are, your lab. Lab came back showing elevated total bilirubin, and the direct portion is high, so I can say this is obstructive jaundice. What confirming this? Alkaline phosphatase and GGT both are high, saying this patient has cholestasis, okay? And there is a bit positive transaminases, ALT a bit high and AST. And you started to gather your information. You are thinking that this patient might have infection, but guess what? White blood cells is 8.9 and CRP is 12. Hemoglobin is normal, platelet within accepted values, and lipase is normal. Okay. It's a bit confusing, but what I got finally, I have obstructive jaundice. So let's take our POCUS and look for the source of obstruction. I'll take my right curvilinear probe and I will examine the biliary system in the mid-clavicular line with the costal margin. I'll ask my patient to cooperate with me to take a deep breath to check the gallbladder. This is the first POCUS finding. What do you see here? Signs of cholecystitis. Let's revise it together. That I have dilated gallbladder. Okay, I have here dilated, very dilated gallbladder. Okay, but I cannot see wall thickness. Okay, increased wall thickness. I cannot see pericholecystic fluid. I cannot see any stone inside. Okay, let's go for the next exam, which is for the liver. I can see here intrahepatic biliary dilatation. Okay. And so where is the stone? It might pass from the gallbladder going down to the CBD, causing obstructive jaundice. Let's go for the CBD. When we went to assess the CBD, as you see, by the eyeballing, what's your comment? It's a normal CBD. When we measure it, it's 0.35 centimeter. It is 3 or 4 millimeter. And we know that the normal value can reach in normal patient to 6 millimeter or 7, and it might reach to 1 centimeter in patient with cholecystectomy. So what we have here, we have right upper quadrant pain with jaundice. I was looking for fever to say this patient has what's called by Charcot triad to diagnose patient with cholangitis to start the treatment. But I don't have fever, so the triad is not complete. And definitely the BNTAD, which is the Raynaud BNTAD, with loss of conscious or hypotension, is not there. Our patient is alert. She's not in hypotension. Labs show obstructive jaundice. I have dilated gallbladder, no obvious gallstone, no wall thickening, no pericholecystic fluid, dilated intrahepatic biliary duct, and normal CBD. Where is the obstruction? You have to look deep and get another POCUS finding, POCUS view. While you are in the same position, okay, try to get the whole length of the gallbladder. You have to see the fundus, you have to see the body, you have to see the neck, and close to the neck, there is what's called by Hartmann pouch and cystic duct. If you can see hyperechoic structure, okay, with posterior acoustic shadow. There is stone, but this stone in the cystic duct. It's okay. And it's a cystic duct. Why we have intrahepatic biliary dilatation? Because we have now what's called by Merisi syndrome. Merisi syndrome, it's impacted stone in the cystic duct or Hartmann pouch, which is causing external compression to the common hepatic duct. And its characteristic, you will find a distended gallbladder with or without stone, and you will find intrahepatic biliary duct, common duct dilatation and intrahepatic biliary system dilatation, but you will find normal CBD. Is it emergency? Yes. This is another video for another case showing. Okay, this red arrow showing in the examination a stone, and this is another case, clear, distended, hugely distended gallbladder, and there is a stone in the cystic duct appearing here. I'll show it to you again. Yes, here. Okay, hyperechoic structure with posterior acoustic shadow. Okay, we reached to the diagnosis that we have Marizzi syndrome. Why the gallbladder appears stone-free? Because the stone may be hidden in the Hartmann pouch, impacted in the cystic duct, and it's difficult to visualize in your routine gallbladder review. Okay, so normal appearing gallbladder doesn't exclude biliary stone disease. You have to have you in your mind the Marizzi syndrome. What I'll do now, if I have patient stable like our patient, you will admit your patient under general surgery because it's a surgical emergency. Sometimes they use MRCP before they will go through the surgery. And if your patient is unstable or become feverish, disturbed conscious level, or he has any diagnosis saying that this patient has cholangitis, you have to start a broad spectrum in the antibiotic from the emergency. You have to go through the sepsis pathway, and urgently you have to do biliary decompression, either using the ERCP if the case fit or going for surgery. Marizzi syndrome is a surgical treatment, definite treatment is a surgical most of the time, cholecystectomy, and by the way, in the surgery suite, it has a lot of classification, but for you, at least you get the diagnosis from the emergency. Take home message. Dilated ducts always mean obstruction, so then you send your patient home even with after simple analgesia and not investigated well. Stone-free gallbladder doesn't exclude biliary pathology. Put in your mind that the Marizzi syndrome should be considered when biliary obstruction existing without an obvious CBD stone. Thank you so much. The floor is yours.
Thank you very much, Dr. Ahmed. It was very nice case also. Thank you. I think, Dr. Haitham, that we don't have questions for the cases, but really it's very, very interesting, two very interesting cases. And the second one as well highlighted very important lesson here, which is because sometimes we see people, once they see the gallbladder without signs of cholecystitis and with no obvious stone, they stop here and they believe that the presentation is not because of calcular cholecystitis or calcular complications of obstructing the path of biliary fluid. So it was a very clear message, Dr. Ahmed. Really, I enjoyed it. Thank you very much. Dr. Haitham.
Yes, thank you, Dr. Ahmed. Actually, a very nice presentation. And my advice to my colleagues and to myself, use the POCUS in the acute abdomen. Search for the different causes, especially if the patient is unstable and even if the patient is stable, because ultrasound is very, very sensitive in the acute abdomen in the emergency department. So now it's my pleasure to present one of our figures. He is Dr. Salahat Meza. He is from Palestine, from the Heroes, and he is the president of the Emergency Society in Palestine. They are working in a very difficult situations with lack of resources, working 24 hours. So it's a pleasure that he gave us some time to share with us some of his
roadmap here, how to deal with the patient if a patient came to the emergency department with chest or abdominal trauma, blunt or penetrating, or multiple trauma, stable or unstable patient, when to use a fast and eco-fast exam. It's the roadmap to use. First, when to use a fast exam before in primary survey or in secondary survey. In a primary survey, post A, airway patent or compromised, then B, breathing. If a fast exam negative, a patient is vitally, dynamically stable, yes, further diagnosis, we can go to a CT scan or observation or repeat fast exam. A patient is stable, no, you can go to reevaluation for further source of shock or consider repeat fast. If patient is with a positive fast examination, hemodynamically unstable, yes, immediately we can go to laparotomy or diagnose control surgery. Damage control surgery, it's if a patient of no, consider CT scan or closed monitoring. It's the map road for every trauma patient. Next slide. Fast exam. Definition. Fast is a rapid bedside ultrasound examination to take the free fluid in the peritoneal or pericardial and the pleural space in a trauma patient. Hemodynamically unstable trauma patient, blunt or penetrating abdominal traumas, suspected thoracic injury or cardiac tamponade evaluation. Advanced, it's rapid, non-invasive, we can repeatable, increase diagnosis across treatment space. And we have 4 views for any fast ultrasound in blunt or penetrating trauma in chest and abdomen. The first view in right upper quadrant in the Morrison pouch, we can assess the liver and the kidney. Left upper quadrant splenic, spleen and kidneys. Pelvis pouch, bladder, rectum, subxiphoid, pericardial effusion, lung, pneumothorax. We can assess every trauma for these 5 views. It's the roadmap for every trauma patient. Next slide. I have 3 short case scenarios. It's a real cases in our hospital, but I will show the first cases, patient information, age 32 years, male, chief complaint, shortness of breath and right-sided chest pain following for motor vehicle accident. Next slide. History of presentation illness. He was brought to the emergency department after a motor vehicle accident. He was resident driver and sustained a blunt trauma to the chest from impact with ring. On arrival, vital signs. Yeah, vital signs. Severe right side chest pain, progressive shortness of breath, difficult deep breathing, no loss of consciousness. Respiratory rate 32, 88 saturation, decrease the breath sound over the right hemothorax, reduce chest expansion on the right side, heart rate 125, blood pressure 80/60, capillary refill time 3 seconds. Yeah, and this, the view, you show the view to confirm the diagnosis. It's a final diagnosis here. You can it's an diagnosis pneumothorax. Well, yeah, pneumothorax diagnosis. No need to go to refer patient to do CT scan or chest X-ray or likely in ATLS treat before X-ray or not treat after X-ray. You can just take one view to manage the patient to insert it chest drain, and the patient is 100% safely. It's the first case. Second case is another patient, 57 years old, came to the emergency department with sudden onset of right flank pain, sharp pain. Patient is sweaty, severe in pain. In past history of this patient had a kidney stone. First impression is this patient came to clinical presentation, renal colic. This patient has a renal colic 100%. When did it a first view for kidney, right side, okay, I think it's a confirmation diagnosis for renal colic, kidney stone with severe hydronephrosis. Went to another view. Yeah. We have a video here, yeah, Dr. Haytham. Yes. Okay, patient came with flank pain. The impression is an renal colic due to kidney stone or ureteric stone, but this patient have an abdominal aortic aneurysm, not a renal colic or stone. And another case, 56 years old, female, history of breast CA, came to our emergency department with severe tachypnea and respiratory rate 40, DSAT, hypotension 85/50, distended neck vein. The examination or the first impression, this patient had in chest X-ray bilateral pleural effusion, and he did it thoracentesis before came in other hospital. And when see him by ultrasound, yeah, Yeah, this patient had a tachypnea and a high respiratory rate, not because had a pleural effusion. It's not a pleural effusion, it's pericardial effusion. Final diagnosis, pericardial effusion, management inserted big tail, evacuated 6 ml of blood fluid. The last 3, how to use point of care ultrasound during CPR in a trauma cardiac arrest. The goals: identify immediately cases of trauma cardiac arrest. You can show in cardiac tamponade, tension pneumothorax, massive hemothorax, only 5 T's and 5 H's, massive hemothorax, severe hypovolemia or hemorrhagic cardiac activity. Okay, cardiac ultrasound, sub-exiphoid. It's what view we need in patient during trauma patient or in cardiac arrest during CPR. Key point: the sub-exiphoid cardiac view is usually the best view during active CPR. Ultrasound should answer a specific question. Why is this patient in arrest? Don't prolong pulse check to obtain perfect imaging. The most important reversible cause in blunt chest trauma are cardiac tamponade, tension, or hemothorax, massive hemothorax. During the pause and intervention, this after compression restart. As the last slides. And thank you for your attention.
Thank you, Dr. Salah, for sharing with us some of your cases and your experience. Actually, using the ultrasound is essential in trauma patient, either in pre-arrest or even if the patient is arrested. It is very sensitive, as Dr. Salah showed us, in the pneumothorax, and you can depend on it for management. Also, if the patient is very arrest, you can exclude reversible causes for arrest like hypovolemia, like hypoxia, pneumothorax, and cardiac tamponading. And even if the trauma patient arrested, you can use it to confirm the rhythm. Either the patient is pseudo-pulseless electrical activity or true or fine VF or asystole. So it has a great value. Also, one of the tricky cases, the patient with loin pain who has aortic aneurysm. If anyone has any question to share with Dr. Salah, you can share it in the Q&A. And here is one question that is asking why you say this patient has a pneumothorax, not a hemothorax for the ultrasound for the first scenario.
The first scenario?
Yes. We mean,
Yeah.
how did you judge this is a pneumothorax from the ultrasound?
The ultrasound, first clinically, patient came with decreased air entry in right side. Does that mean we have jugular vein distended? Clinically is going to, patient go to with the tension pneumothorax. It's not an hemothorax. By view, you see the slides. It's it's not an pneumothorax. It's a pneumothorax.
Yes, because the pleural line is not sliding also in
The
the
pleural line
MOD.
not sliding.
Yes. Okay. If there is no other question, there is another question. Want to insert the chest tube in the pneumothorax patient? Mean amount. There is a question. He says when you decide to insert the chest tube in the pneumothorax patient.
We did it. We inserted the chest drain, and the patient is improved.
Yes.
The patient is, it's the first view. When patient came to our department, its early signs came to with the not. We don't have ultrasound before. We clinically diagnose patient with is tension pneumothorax. Early signs, late signs, patient go with the jugular vein distended and shifting the trachea in the opposite side, in the left side. We inserted and the patient is improved.
If you allow me, Dr. Haytham, the indication to put intercostal tube, as Dr. Salah said, when you have the clinical scenario, and then the advantage of lung ultrasound over the chest X-ray, which again it's equal to CT. Instead of sending unstable patient for CT exam, this might be dangerous. You do point of care ultrasound bedside, and if you see signs of pneumothorax in the clinical scenario, so you have trauma patient, and then you don't see the pleura sliding, and then you move your probe downward and laterally till you find what the Dr. Salah showed us, the lung point. When the sliding meet, when the no sliding meet the sliding. So there was no sliding. You move the probe laterally and down, one space, one space, one space, till you see the sliding is back. So you would measure how big is the pneumothorax from the point you started with, which should be the second intercostal space, mid-clavicular line, either on right side or left side. And then you move your probe, and then you can measure how many centimeters till you find the lung point there. So the sliding is back again. But the most important here is the clinical scenario. If I have somebody who is hemodynamically unstable and I see sign of pneumothorax, this is tension. You don't look at any other thing. You just insert the needle decompression and then do the intercostal tube. 1. 2, if I have pneumothorax with somebody who's hypoxic and respiratory distress, respiratory failure, then you don't wait. If somebody with a chest pain, so clinical case scenario with signs of pneumothorax, especially if there's hemodynamic instability, i.e. tension pneumothorax, or desaturation, i.e. hypoxia, then you have to insert intercostal tube. Thank you.
Yes, thank you, Dr. Ashraf. I totally agree. It's a clinical judge. You diagnose it's a pneumothorax, and the patient is desetting. The patient is deteriorating. Blood pressure is going lower. So you have to stabilize this issue, and you have to insert the chest tube to avoid deteriorating of your patient. Now, for the last speaker, Dr. Hisham Timraz. He is a consultant interventional radiology, and he is one of the scientific committee of Sono School, and one of our speakers. He will share with us some of his interesting cases in the advanced POCUS for patients with acute abdomen and some pediatric patient also. So, Dr. Hisham, you can start.
My voice is clear, I think.
Yes.
Now, my presentation will be a case, a tricky case of POCUS gallbladder. The patient was a 61-year-old female with known metastatic ovarian cancer, and CT is show abnormal gallbladder. This CT was done routinely for assessing the patient case. We went to know the staging of the to restage the ovarian cancer stage. So we performed this CT. The patient had some few pain in the abdomen and nothing else. Actually, we found in the CT abnormal gallbladder plus adjacent collection. The abnormal gallbladder, it's human. It has something like a tissue, and we didn't know by CT. We have no idea about what is this content inside the gallbladder lumen. Is this fluid? Is this the debris? Is this mud, or is this metastatic tissue from the ovary? The patient had no fever. There was no jaundice. CBC negative for leukocytosis, and the Murphy sign was negative by examination. Actually, we're now after the CT, we want to figure what happened on the gallbladder. So we return a step back and return back to the routine point of care ultrasound. We bring the ultrasound machine and we start to do POCUS ultrasound gallbladder to know what happens with gallbladder, what is this abnormal content inside the gallbladder. As shown here, this was the longitudinal and transverse axis of the gallbladder, the B mode. It shows the gallbladder lumen, which has some echoes, debris also, and there was also gallbladder wall thickening associated with hyperemia by color as shown, and there was mild dilatation on the CBD. The patient bilirubin was not in the normal range, so there was no jaundice as we say in the clinical picture of the patient. By point of care, we have two important information. The first one is that we still have something inside the gallbladder lumen, which may be debris, or vascularized tissue or metastatizing tissue from the ovarian cancer. We still don't know what is inside the gallbladder. The second thing that we know, that the point of care told us that there is a gallbladder wall or mural thickening. The mural thickening is diffuse, and there is a collection beside the gallbladder lumen. So on the board, we start to think what is going on, what happened with this gallbladder. We didn't surely answer our questions, because this question will change the management hierarchy. One management will be if this metastasized gallbladder from the ovarian cancer, it will be go for chemotherapy and go for its way. But if this something surgical, it should go to the operative room, or we perform cholecystostomy. So we think to do something. Now this is the question we want to answer: is the gallbladder the thickened was intact or not? Actually, we didn't find the stone inside the gallbladder wall. These are the findings we have by the B mode: the irregular thickened gallbladder wall, the hyperemic wall on the Doppler, luminal debris or tissue we still don't know, and the gallbladder stones. We decided to form something advanced on this case, which is called contrast enhanced ultrasound. The simple idea of the contrast enhanced ultrasound that we bedside in the bedside we give a contrast enhancing agent specialized for ultrasound, and this agent will make the vascularized tissue or the tissue which has the blood supply to be colorized as appear in this image, and any fluid or the thing that it doesn't has any blood supply, it will be non-vascularized. So we start to inject the patient with the contrast enhanced ultrasound agent, and we found this photo comes also. We did the longitudinal as routine. We did the longitudinal examination of the gallbladder, the transverse scan of the gallbladder, and this photo appears in which there is this lumen is the gallbladder lumen wall. The wall here take color, so it means that it is vascularized gallbladder wall, and here in this site there was a defect in the gallbladder wall, and this defect is continuing with collection beside the gallbladder lumen. So now we have gallbladder, we have defect here like here, and we have a collection beside the gallbladder. So we start to shift our think that this is perforated gallbladder. It's not cholecystitis. The lumen inside the gallbladder, it has no vascularized tissue, so there is no metastasis from the ovary. We answered this question. And the defect inside the gallbladder lumen wall is continuous with collection, which is contained collection. As here, it's not free collection; it is contained collection. We perform the rest of the fast scan of the patient. We don't have fluid of any site else except of this site. It's a localized collection. So the clue for answering this case was the focal wall discontinuity, which is called the hole sign. The contrast enhanced ultrasound was the expert move in this case. It answered the wall is perfused. Yes, the wall was perfused. Is there a wall defect? Yes, there was a wall defect. Is the collection vascular or avascular? It was avascular collection and avascular content inside the gallbladder lumen. So it wasn't ovarian metastasis as we think in the start of the case. It is a simple fluid or complicated fluid from the gallbladder. This video shows what happens when we inject the contrast enhanced ultrasound immediately. The image on the left, this one is the for what appears on the screen after we start. I will start the video now. By starting the video now, the patient was injected immediately. After that, we still using by the real-time scan to scan the patient on the gallbladder area, anatomical area or sonographic area of scanning. Here, the lumen of the gallbladder start to appear, and the collection beside the gallbladder. This is the wall of the gallbladder, and this is the content of the gallbladder, which has no blood supply. And this is the defect as appears here in the wall, and this is the fluid collection that appears beside the gallbladder. So now it's a case of perforated gallbladder. The contrast enhanced ultrasound, as we said, reveal enhanced gallbladder wall, fundal wall defect, communication with adjacent collection, and this collection, which is very important point, was avascular collection. So we have no enhancing tumor mass. It was classified as something called the Nemer type 2 gallbladder perforation, which is the type of perforation that contained perforation, localized abscess or biloma beside the gallbladder defect. This case was tricky because the Murphy was negative. There was also inside the bladder. There was no jaundice, and the cancer background confused the picture and make a very difficult differential to us to exclude, which was the ovarian metastasis to a gallbladder, which is rare but occasionally happens in these cases. The thing that differentiate the abscess from the tumor in this case was the contrast enhanced agent. The vascularity inside the cavity confirms the diagnosis. It was internal debris and communicate with the wall defect. It's very important to say that it is the perforation and the leak is contained or free, because this has changed the management. Is there drainable target? Is the gallbladder itself was drainable? The management of this case was with we put inside the gallbladder, we perform cholecystostomy, and we drain also the collection that beside the gall bladder. So it's very important. There was gallbladder thickening, there was negative Murphy sign in this case, focal wall defect communicated with collection, and the bile was inside. Take home message: always assess the wall integrity, always assess the complication, put your drain plan and escalate trigger. And thank you very much.
Uh, Thank you, Dr. Hisham, for this advanced and interesting case. If anyone has any question for Dr. Hisham, please write in the question and answer.
It's a very good case, actually. I had one case recently here in UK, and it was diagnosed actually with a CT. We couldn't. I was not there, so they did a CT, and then next day they told that we have this case, blah blah blah, and then I want to learn now from Dr. Hisham. What is this contrast, and where you inject it? Do you have any preference to be injected in a central line, or in where do you inject the contrast, and what contrast is it? Because we rarely in point of care ultrasound, so, and I'm sure that the fellows will say that we are just going with the basic and semi-advanced modalities. So this is a bit advanced. So can you elaborate more on the contrast enhanced ultrasound, Dr. Hisham?
Actually, contrast enhanced ultrasound is one of the most advanced techniques or upgrades in the ultrasound platform used all over the world. Maybe 10 years before we started to use the contrast enhanced ultrasound agent. It's very common in USA and Europe, and also in China, Japan, but it's less used in Turkey also, but it's less used in Egypt and our Middle East area. Actually, the contrast enhanced ultrasound agent, it comes in ampoules, maybe 1.5 milligram milli inside the ampoules. It consists its content is something like bubbles. These bubbles, when it's hit by the ultrasound waves, by the ultrasound waves, it bring the picture that I show in the lecture. Actually, it's injected in the peripheral cannula, or no need for central line, something like this. Any peripheral cannulation is okay and accepted, and the patient is injected by 1 milligram of the contrast. Actually, the contrast, which is very important about, it's 100% safe. It needs no creatinine ratio or creatinine level. Not as the iodinated contrast of the CT or MRI, we need to check the creat level or the kidney function of the patient. But about the ultrasound contrast enhanced agent, it's very safe. It has no relation to the kidney function or the liver function of the patient. Maybe
And it reached the gallbladder after how long?
the route is a little bit costly. It's a little bit expensive, but it is very safe, and its result is very good, especially in the cases that we want to see the vascularity of something. We want to see the vascularity of tumor inside the liver, the viability of wall of gallbladder, such as the case I presented, or something like this. Very valuable, it has high sensitivity and specificity and all the ratios enhancer sound is actually there is no danger. It can be done in the clinic or bedside of the patient, or not, no need for high preparation or
So
high licensing to this agent. It's very safe, and
when you inject it, Hisham, it goes after how long? And after how long you put the probe on the gallbladder area and see it? Few minutes, 1 minute, 2 minutes.
once 1 minute, 1 minute from one to and from one from 60 seconds to 90 seconds. Start to according to the area you want to scan. For the liver and gallbladder, it's from 60 to 90 seconds, just to start to hold to take your image. But the thing that after you inject immediately, you take your probe, you hold your probe, and put inside the put it on the anatomical side of the gallbladder or the liver or the any can we unlock the freeze and wait
Thank you, Dr. Hisham. Would you share with us some of the pediatric cases?
How many minutes, Haitham, for the webinar? We're already 1 hour and 20 minutes. So
yes.
how much you would give Dr. Hisham? How many minutes you give him to finish?
I think 10 minutes.
Okay.
Okay, Dr. Hisham.
Okay, now very fast. I will go for the pediatric application of the point of care ultrasound. The first thing with skin and soft tissue, which is very simple but very valuable application for POCUS point of care in pediatric. This is the case after left hand. This is left hand swelling. The patient, 2 years old, presented with the left hand swelling like this. The patient was afebrile. He claims no trauma, nothing in the no foreign body inside the under bitting him or go inside the skin. But the point of care ultrasound actually by the superficial probe it shows edematous skin, subcutaneous tissue, and start layering of fluid that start to accumulate inside the patient arm. Actually, the patient management was there was no drainable collection in this patient, and so the management was just topical antibiotics and something anti-inflammatory, and it goes like this. This is in contrast to the previous patient. Here, there start the bucket of fluid to accumulate inside the subcutaneous tissue edema. This is the same presentation, hand forearm swelling, but we have here a fluid collection. This is a drainable fluid collection, and this was abscess, and it was need to open by a surgeon just to get rid of the infection risk in this patient. This also a different superficial application of pediatric ultrasound. Here, 7 years old male comes with the scenario of foreign body in the right foot. Actually, by the ultrasound examination, we find the foreign body. It looks like here in this area, and this and this make the removal of this foreign body is very important to get rid of the infectious process, which will end with abscess surely in this patient. We remove the foreign body from the patient like this, and ultrasound helps us so much. Actually, these three applications are very simple, but actually very valuable to help the patient. The eFast application on the pediatric, which is very valuable. This patient comes in a classic trauma scenario, and we performed the eFast scan, and it was negative. There is no fluid in the hepatorenal pouch, and the div-external view. There is no pericardial effusion, and we continue renal and the urinary bladder. Actually, the first scan was negative. This is in contrast to this patient, which can come also in a trauma scenario, but there was a pericardial effusion like this in the CV external view. There was a fluid in the hepatorenal pouch like this in this patient. So the triaging of this patient different from the previous one, which this need follow up and CT scan if applicable. Some very common pediatric abdominal pathology, in which the ultrasound POCUS or point of care ultrasound plays a great role. Anyone know what is this sign called? It's something like a kidney or something like a target, which you can throw your arrow inside the center. It's called the target sign. It's very common with something called intussusception, which is very common in the young infants or the early infants. The patient comes with abdominal pain, vomiting, right upper quadrant mass. Of course, current jelly stool is very important clinical presentation of the patient. It happens between 3 months and 6 years. High specificity for POCUS ultrasound and high negative predictive value. Actually, our technique in the intussusception examination that we bring our superficial probe we adjust the depth for 6 centimeter and start to sweep superior laterally from the cecum to the hepatic flexure. This is the most common area for the intussusception. Actually, we scan in two planes, the longitudinal plane and the transverse plane. The most common type of intussusception is ileocolic intussusception, in which the terminal ileum goes inside the cecum. So it's like a bowel loop goes inside a bowel loop. So the normal that we have two lumens only in the examination, but when a small bowel loop go inside another bowel loop, we in this case we have four layers of walls inside the tissue. So it's called target sign because it's thickened, or pseudo kidney sign. It likes the kidney, but it is actually not the kidney. Also, interestingly, we can, and I did this in bedside in my real practice. I did 2 or 3 cases for reduction of the intussusception by the anal enema. The surgeon comes with me, and I follow the intussusception area. He start to inject water inside the anal tube. Inject water just to separate the intussuscepted loop for the intussusceptum one. And after he complete his pumping the water, I check by ultrasound dynamically if this intussusception is released or not. And we have a very good result. And actually, it's done bedside, and it's very simple and a cheap way to confirm that the intussusception is released by ultrasound. So the ultrasound helps in diagnosis and help therapeutically in treatment of the cases in bedsides. The second very important thing in practice, pediatric practice point of care, which is appendicitis. Actually, all of us know that appendicitis comes with right lower quadrant pain, fever, pelvic pain, elevated YBC count, and peritoneal signs such tenderness and rebound tenderness signs. Actually, the landmark of appendix examination is on the when we bring the external iliac artery and vein in the right lower quadrant area, and start to search in that area by the superficial probe to see the appendix, which we have a lot of sites for appendix, retrocecal, subcecal, pelvic. pre-ileal, post-ileal. Actually, the sensitivity of this scan is 80-100% to 85, and we some cases, few cases can escape from us. We can't pick up the inflamed appendix by the probe because it has a very difficult location inside the abdomen. This is the this case, and inch of this it exceeds a millimeter long, and this is the appendix like this. It exceeds also meter long, and it beside the iliac vessels. This is a stone inside the appendix, which we called it appendiculis. It's a common finding with appendicitis, and the pelvis we have to exclude if there is any fluid collection or not. The last application for point of care ultrasound in pediatrics, actually this is not in pediatrics, this is in infant specifically. The hypertrophic pyloric stenosis or CHIPS, in which the pyloric canal, there is thickening pyloric canal, and the infant complains of projectile vomiting, unstoppable vomiting, unresponding to anything. When we scan the pyloric canal beside the left lobe of the liver, we find that its wall is thickened. It's more than 4 millimeter, and the length of pyloric canal exceeds 14 millimeter. And thank you.
Thank you, Dr. Hisham. Of course, the pediatric POCUS is trending now. It has a lot of application, especially in abdominal, respiratory, cardiac, intracranial, and different uses. So thank you very much. If anyone has any question, or Dr. Ashraf, if you want to add anything.
No, again, very, very interesting and enjoyable. Thank you very much, Dr. Hisham. And I would like to thank also Dr. Salah and Dr. Ahmed. And of course, I thank you very much, Dr. Haytham, for organizing this wonderful meeting. So I don't have any comment, but and I don't see any question in Q&A. What do you think, Dr. Haytham?
There is I received just one question from one colleague that he asked, yani, sometimes he accidentally find another finding in the POCUS. For example, he has a patient with arrhythmia, low ejection fraction, and when he completed a whole POCUS, he find that also the patient has aortic aneurysm and aortic dissection. So he's asking, should I make like a rapid assessment, or should I focus on the main complaint? He is a little bit confused about this. If you have an advice, Dr. Ashraf, from your practice.
Yeah, this is very, very good question, actually. And it was one of the papers, one of the good work was done before. So the research found that when you do the exam for certain question in mind, you find another thing that is totally away from your mind and deviate the thinking to another pathway. This is common, by the way. Around 30% in this published paper, they found something that was not at all in the algorithm of thinking when you did the point of care to answer. And this 30% was the important. So they divided the finding into clinical case scenario related finding to explain, or finding that are not related to the clinical question in mind. So for example, you have a patient who is with shock, and you are doing the exam to see if they are septic, cardiogenic, and you find something else. This part of the finding were divided into clinically important, non-clinically important, and majority of this 30%, more than 70% of them were clinically important. So yes, sometimes you find something, you dig behind it. If it is can be in the acute pathway of your patient and will make difference in management plan, you have to dig behind. So if you see a mass in the heart, where you're looking to see if there is cardiogenic shock, low left ventricle ejection fraction, or cardiac output, or cardiac tamponade, but you find mass. This is very important, and so on. Yeah.
Yes. Thank you, Dr. Ashraf. Thank you. Yes.
Thank you.
Yes.
Can we conclude?
Yes, please. Yes.
So again, thank you very much for everyone attended tonight, the speakers, the moderator, the ICOM, WICCM, and we wish to see you in the next webinar. Again, we highlight the importance for the fellows to bring their own cases. We need to hear you. Bring your questions, because this will give us a clue that you are following the assignment on the platform. Please go through the platform, watch the lectures, read the journal club, answer the questions, and bring your questions for clarifications, bring your clinical cases for discussion, and see you next live webinar next month. Thank you very much. Bye-bye.
Thank you, Dr. Ashraf.
Thank you.